WebEx log that you are logged in, so that's fine there. For those in the room, there are 2 sign-up sheets up front here, one for the members of the EMPC or their alternates to sign on, and everybody else is a guest or a subject matter expert. I'm signing on that sheet there. Just so you understand, the EMPC relies on subject matter experts from time to time, because the EMPC consists of generally the emergency department folks and the ambulance folks, the helicopter folks, the folks in emergency medicine and pre-hospital care. But if we step a little bit outside that realm, then we need subject matter experts, and that's why you're here. But the EMPC is a public body under the Board of County Commissioners, appointed by the Board of County Commissioners. So we have to follow all the public meeting rules and the sunshine laws and all of that. So it's very important that we know who you are. So with that, I did create a Microsoft Forms online thing for you to go and put your information in as a subject matter expert, so we can capture who you are and as a participant or a subject matter expert with this committee. So folks online, I will get that to you if you don't have it. For the folks in the room, up at the table here, there's a one-pager with a big 3D barcode on it. Just grab that if you can, and you could just scan that barcode or use that link, and it'll take you straight to the form. Just fill that form out for me. And for those of you who don't do that, after this meeting, I will track you down. This is a large committee. There's 19 EMPC members and 14 of their alternates on this committee. They're not all here today, obviously, but there's that many EMPC members here, and there's 25 subject matter experts signed up. So this committee in total is 50 to 60 people. It is the largest committee we have. So there's a lot of involvement here and a lot of pieces to coordinate there. So I appreciate your understanding all the emails and everything else that I try to coordinate amongst 60 people. As I said, the EMPC is a publicly appointed body by the Board of County Commissioners, and their mission is to coordinate all of emergency medical services for Hillsborough County. They've been in existence since 1973, so been around a long time. The Cardiac STEMI Committee is a committee of that EMPC, and we have to follow the same sunshine rules here. With those sunshine rules, one of the things is that the only people who are allowed to vote on this committee are the EMPC members assigned to this committee. Subject matter experts do not vote here. Your input is very valuable. We want you here. We want to hear what you have to say, and your input will greatly influence everything that happens here. That's why we need to know who you are. Hence the barcode thing. But please understand that anytime we take a vote, it is only the EMPC members or their respective alternates that would be voting and would count for the vote. Same thing when I do roll call. The roll call will only involve the EMPC members and their alternates. It will not include the subject matter experts and the guests. So just so you understand that piece. For this to be an official public meeting, we have to have in-person quorum. Now there are 19 EMPC positions right now assigned to this committee. Quorum is one more than half. That means we need 11 EMPC members or their alternates to be physically present here in this room, not online, but in this room here, to have a quorum so the committee can do business. If we can't do business, if we don't have quorum and can't do business, then it becomes information only. Now, what constitutes business? Anything that would require a vote, anything that would be passed from this committee to the full EMPC, anything like that requires a vote of the majority vote of the EMPC members present in this room. Right now, we don't have that. So this will be an information-only meeting at this point, and we will work on that as we go. Let me see. All right, personal notes. So one of the things that happens when you coordinate a meeting is you're so busy doing the coordination in the background that you don't really get to listen to the meeting. So when writing the minutes of this meeting this past week, I'm listening to the recordings, and I'm like, wow, I forgot that, I forgot that, I forgot that. And I just want to say that it was a remarkable discussion at the last meeting. There was a lot of good information and evidence about why such a system is needed here in Hillsborough County, regionally across Tampa Bay and the West Central Florida, across the state of Florida, and I think nationally also. It was a very collegial meeting in that the SMEs who have stepped up to be involved in this. Remarkable that on the recording from the last meeting, there was like, hi, I'm so-and-so from this hospital. Hi, I'm so-and-so from this hospital. Getting involved in this. Much appreciate, again, you're all the subject matter experts, all you folks getting involved in this. And some of you at the last minute. Hey, you ought to be at this. Okay, when's the meeting? Monday. Oh, really? So I think we made a good start, is my point. And since the last meeting, there were two things that we did. We drafted the triage criteria, the triage, what the criteria would be, again, a draft, what the triage criteria would be to triage MI patients in cardiogenic shock from the field to a resuscitation center, I guess we're calling it. If that's not the right term, forgive me. And we worked on updating the committee participant list, and that is a work in progress because there's 60 people here. And when we started, I got the email list from Dr. Joel, and there was 150 people on it. So we got some work to do here. So just one final note here. I think there was a lot of good discussion last meeting. There was a lot of good progress made from the last meeting. This committee typically meets only every 6 months. I don't think that we want to do that going forward. That'll be completely up to Dr. Strom as the chair of the committee and Dr. Sand as the chair of the EMPC. But I just want to give you all a heads up that if you are used to this committee meeting being every 6 months, I think if we're going to keep the momentum for this project, we need to meet a little more often while we get through this project. Just my opinion and just my observation from the last meeting and the progress we made from the last meeting and since the last meeting. So, Dr. Sant.
Thanks, Mike. That was a grab the button. Okay. Thanks, and thanks everybody for coming here and everybody online. We appreciate it. Just want to thank Dr. Strom and especially and the folks at Tampa General Hospital for really doing a lot of work in the background. You'll hear some of that update today, but thank you everybody. And I'm going to really turn it over to Dr. Strom. He's done all the work to put this together and a lot of work in the last few months. Dr. Strom, thank you. I don't know if you want to sit down or stand.
So we'll need to do roll call.
Well, one thing I'd like to add, there's periodically people come and go. They replace other members who've left to do other things. And if you replace somebody who's on the committee or a subject matter expert, please let Mike and I know, and we can add you to the email list and remove the unnecessary people. That will keep some of the edema off the list, because it's become a very large list. But it includes a lot of people, a lot of the EMS services, the hospitals, with the various level hospitals. And so I think it's very important that we have a large committee because we are a large county. We have 1.3 million people, and growing every day. I mean, they may buy my house if I sell it, if I have a house. Actually, when we got home from London a couple of weeks ago, we walked in after midnight, and there was a leak in a pipe, and with a hallway we had to cross the Red Sea, or the leak. Anyway, we're still dealing with that. So anyway, what I'd like to do is, well, I'd like to get the roll call.
Switch microphones here. I'll grab this one.
Okay.
Okay, let's take roll call. Dr. Sand. Dave Travis.
Here online.
Dr. Strom.
Here.
Dr. Thomas. Charity Carlisle.
Here on the phone.
You're online, Charity?
Yes, sir.
Okay. Can't hear you very well, but that's okay. Gotcha.
Sorry, I'm on the phone.
Jill Mendez. Hello, Jill. Um, Just so everyone knows, Jill Mendez is a candidate for the EMPC. Her application is in vetting at this point. She is not officially a member of the EMPC. We have a couple of people in that same boat. Jill will not be able to vote at this time until she is actually a member or an alternate of the EMPC. But just for yourself, Jill, and anyone else who's in that same boat, if you're not officially appointed to the EMPC, but you're in vetting, you still cannot vote. Just,
Hey, Mike?
yes, sir. Who's that?
Hi, this is Dave Travis. Were you able to hear that I was here? I'm not sure if my mic was working.
I'm sorry, having trouble hearing you.
Just making sure you heard that I was here. I'm not sure my mic is working properly.
Oh, Dave Travis?
Yes.
Yes, we got you, Dave.
All right, thank you.
Thank you. Yep. Dr. Sobke? Where are we? Hello, sir. Dr. Sobke, I sent you a note this morning. Don't run away until I see you, okay? Chief Burnett. Chief Maxwell. Aaron Skiba. Michelle Moran. Jeff Youngblood. Brittany McCollum. John Visicay. Kathy Cope.
Present.
You still online, Kathy?
I'm still here. I guess I still have low volume. Sorry about that.
That's all right. We got you. Thank you. Alexis Rogers. Brooke Shepard. Dr. Shepard. Hello. Chief Tripp. Barbara Tripp.
I'm here online.
Thank you, ma'am. Chief Ship. Christopher Ship. Noreen Schramm.
Here online.
Shirley Bardell. Stephanie LaForest. Philip Chu. Tim Balling, Dr. Balling. Katrina Cordero, Dr. Cordero. Christine Van Cott, Dr. Van Cott. Dr. Raymond Solinsky.
Dr. Slazinski, present online.
Thanks, sir. Robert Kabish.
Present.
Dr. Sasson, Andre Sasson.
He's on shift today.
Okay. Dr. Richard Rodriguez. Dr. James Robelli. Casey Chilton. Hello, Casey. And Dr. Todd Jontek. Okay, so we have 8 EMPC members or alternates present, which means we don't make quorum, which means we can't do the minutes of the last meeting. We can't vote on those, is the first thing. And any actions to be taken, we'll have to, we can talk about it, but we can't actually take action until we have quorum at next meeting. But this should be a wonderful discussion because there's a lot of good people here in the room. So
Okay.
I think that's all the spiel I have. Doctor, go for it.
Thank you for coming today. We really appreciate it, especially that the new spiky balls are out. As you've all heard, that the mask mandate for air travel has been extended for another 2 weeks. I thought it would have ended, but we got to watch out for those spiky balls. The main purpose of today's meeting is to develop the committee that's going to write the protocols for the cardiogenic shock, STEMI cardiogenic shock patients. The last meeting we had, we reviewed the current literature, and I have those slides up again so we can take a look. And Debbie, Hyman, Becerra, and Gil and Debbie were from TGH were presented the protocols that were used that have been developed in Detroit and Cleveland. And we're now going to figure out how to go further. I would like to show a couple slides very briefly, and then I'm going to turn the meeting over to Debbie Rindy Hoffman, or Dr. Rindy Hoffman, to discuss where we are, what elements of the protocols are essential, and how do we get our committee to get together. I'll add to that as we go along, since I blindsided her. Okay, so going from the last time, this came from a paper by Alice Jacobs that appeared in circulation in 2021. Okay, I'm sorry. Oh, somebody wants to hear me? Anyway, the whole point is, I want to emphasize that this protocol will include everybody. All three-level hospitals that are the primary, the STEMI referring hospitals, the basic primary STEMI, and the comprehensive STEMI centers. The difference between the last two is whether or not you are fully committed to treat patients with cardiogenic shock, and that you have 24/7 cardiac surgery and the advanced mechanical support systems that are now recommended. So if we go to 2, we can see, go back please. We can see the elements of the system. And finally, 3, and this is most important. One of our missions is going to be to develop a Cqi process. You can't do anything without knowing what you do, where the weaknesses are, where the strengths, and how do we modify the system to improve delivery of care. Next slide, please. Okay, these are the 3-level systems. The level 1 are the comprehensive heart attack systems. And you can see the 24/7, 365 STEMI receiving hospitals. By the way, these guidelines are now part of the AHA-ACC guidelines. They have cardiac surgery on site. They have a cardiogenic shock protocol and all capabilities, and they can do it enhanced hemodynamics and support for out-of-hospital cardiac arrest. So the whole system includes STEMI, out-of-hospital cardiac arrest, and cardiogenic shock capability. The level 2 centers are PCI 24/7, 365 days, PCI capable. And these would be centers that have a cath lab that can do PCI. They have met the standards for the number of successful PCIs, and they have enough operators to make sure they have 24/7, 365 days coverage. And finally, level 3 are STEMI referring hospitals. They don't have an interventional cath program, but they have a protocol set up so they can transfer patients. And in Hillsborough County, I've actually gone through the distance time of transport without helicopters, unless you're flying at Mach 2, and then we can go to London. That you can, every place in Hillsborough County, I did this when I was at USF. I had a student, EMS can transport by ground a heart attack patient, a STEMI patient, from anywhere in Hillsborough County to a PCI level 3, definitely a level 3, and in those rare cases, like when Interstate 75 has closed, to a level 2 center within 30 minutes. Just driving at normal highway speed. We did this through one of the computer software apps. So it can be accomplished. But if the STEMI receiving hospital cannot transport a cardiogenic shock patient, especially, they can begin giving thrombolysis and other treatment modalities. Next slide, please. Okay, this is the recognition of potential cardiogenic shock in the field. Now, this is going to be a very important component of this whole program. EMS is going to have to acquire the skill sets to recognize patients with potential impending or actual cardiogenic shock in the field, so they know to transfer the patient to a center capable of handling those patients. And again, this may be a bone of contention, and we're going to have to hash out the issues, but this is going to be an important mission for EMPC. And those are the criteria, and we're going to go through them, simplify them, and establish a in-the-field protocol to deliver. And Debbie is going to be very useful. Dr. Hoffman, Randy Hoffman, is going to be very useful in that. And I want everybody, representatives from all the EMS and all the hospitals, to participate in developing this approach. Next slide, please. Okay, this came out of a paper by Tim Henry that it was in 2021, and policy recommendations for STEMI receiving hospitals, again, AHA guidelines. And you can go through them and in all details. There's nothing surprising, but it does set standards for a Cqi process. This is the basis. Next slide, please. Okay, now, this came again out of, this is an AHA recommendation by Tim Henry and colleagues. And this is consideration of early mechanical support based on shock classification. And we'll send this around everybody. I won't go through this in great detail because it's hard to read, but this will be a guideline for how we develop a protocol based on the shock classification that's been developed by AHA and STEMI. Next slide, please. And finally, an algorithm. And again, this is a suggested algorithm that came out of the Tim Henry paper. If you want, I can send these papers to everybody. I make sure that that you can read them at leisure. But the algorithm is fairly straightforward, and it's based on a few physiologic findings, patient's performance, electrocardiographic findings, hemodynamic findings, and then how do you go and optimize the care? So I want everybody to look at that. These are guidelines. These are not. We will have to develop our own approach and our own algorithm, but algorithms approaches are pretty useful. So at this point, I would like to turn the meeting over to Dr. Hoffman, Dr. Randy Hoffman. Debbie, I've known you since 2000. when I came down to Tampa. I got lost on my way to Key West. Anyway, would you like to talk a few words about your thoughts on developing such a protocol? And then I would like to open the discussion for how do we put together a basic committee protocol development, then a committee for quality assurance.
Thank you, Dr. Strom, Mike, Charlie, for inviting us to come to this meeting today. As Dr. Strom said, he didn't tell me I had to speak. So
Well, that's always a good thing.
so it's all off the cuff and I don't have time to make stuff up. Anyway, I think that we have a real opportunity in Hillsborough County to be on the cutting edge of cardiogenic shock care. I think the Detroit initiative that got started a couple of years ago that has now spread to a national initiative has not been well adopted in lots of places so far. And even through the American Heart Association, through which I wear another hat, they are just starting to get these kind of programs up and running in different communities across the United States. So I think we would have a really great opportunity to be at the cutting edge of cardiogenic shock care. And, cardiogenic shock care has changed dramatically since about 2019, not only when we developed the classification system that Dr. Strom showed, but when we've changed our approach to the acute MI patient who has cardiogenic shock. So for the last 30 years, it's been time is muscle, open that vessel, do the fastest you possibly can, let's restore blood flow. But in the cardiogenic shock patient, we have an opportunity to improve survivals from about the 50% range to about the mid 70% range if we can support that patient mechanically first, rest the heart, and then approach with our usual interventions, balloons, stents, et cetera. So I think this is a really exciting opportunity. I'm really excited to be part of it. I think that we have shock protocols that we implement. We have a shock team. We have a multidisciplinary team at this point that whenever there's a cardiogenic shock patient, there's a multidisciplinary phone call that takes place within 5 minutes to include a heart failure specialist, our interventional cardiologist, cardiac surgeon, intensive care physicians, as well as our coordinators. We talk about the case. If everybody needs to be at the bedside, we come to the bedside, make a decision, and plans get implemented. So I'm hopeful that we'll be able to grow from that to even taking care of cardiogenic shock patients in the field, which I think would be the coolest dream of mine, that not only can we take care of them once they get to the hospital, but we can take care of them in the field. I don't know if you want me to talk about the criteria. We have signs all over our hospital about, remember, cardiogenic shock, HHH, hypotension, heart failure, hypoperfusion. So I think that if we can try to keep to those fairly simple criteria, I think we have a game changer.
Any questions? Any comments? Thank you so much.
Okay.
Any? Yeah. So let me get over here so I can talk into the microphone.
Yeah, Dr. Shepard, could I ask you to step up to a microphone so the folks online can hear you? Yeah, I'm sorry. I'm sorry, folks. This is not the best room for this setup.
You can sit here.
Oh, that's okay. My question is quick. Can you just let us know, and we may need to be reminded periodically in this county currently, what hospitals are the level 1s and the level 2s? I think the level 1s in particular, I assume it's Tampa General, St. Joe's. I don't know if Advent has this capability.
Yes.
So that message also needs to be.
It's Tampa General, Advent Health, the Pepin Center, and St. Joe's, Maine are the level 1 centers at this time. I'm not sure how to, where the VA would sit in this, but they have increased their capability. I don't think they're here today. Yeah, oh, you are. I'm sorry. Can you, would you tell us what come on up here and tell us what your capabilities are so we can,
At this time, I believe that we are still a level 3 hospital, possibly going to a level 2. That's what we're in working
Okay.
for.
okay.
Yes, sir.
But hospitals will change their capabilities, and hopefully one of the goals of this project will be to increase the capabilities of hospitals.
Correct. Yes, sir. Thank you.
Anybody else have any comments, questions?
Dr. Strong, when you say Advent,
Um,
there's Advent Tampa and Advent Carrollwood. Which one?
Advent Tampa,
Tampa has,
which has the Pepin Center. That's right, on site.
Surgery on site.
The places that have surgery on site 24/7, 365, and are capable and have the mechanical support capability and the expertise in heart failure, are TGH, Advent Tampa, which used to be University Community Hospital, and obviously St. Joe's, Maine. Those are the main hospitals. Those are the hospitals that ideally, if we can all agree, should receive patients diagnosed as cardiogenic shock in the field. And it should be, how can the patient be transported to one of those hospitals within 30 minutes to be treated? Yes.
I guess to clarify as well, are we talking about all cardiogenic shock patients, or are we talking about STEMI with cardiogenic shocks?
I think it's.
again, I apologize for the microphone.
I think it would be easier to start an implementation with STEMI only, but
Right.
since we have such a big advanced heart failure population in this county, cardiogenic shock is cardiogenic shock. So I would hope to expand that to any patient that has cardiogenic shock.
Okay. And speaking from, I'm an ER physician, I'm also a medical director for an EMS agency, and that, STEMI with cardiogenic shock, I think is definitely one that would be easier to tackle in the beginning. I think saying that all cardiogenic shock patients be taken to one of those 3 hospitals is a big build, because it's not always clear in the field that it is cardiogenic shock, right? I mean, a lot of those things also we see in sepsis patients, right? Or, other diagnoses. So, yeah,
I agree. I totally agree with you.
Yeah.
I think that we should focus initially on field identification of STEMI patients with signs of cardiogenic shock. A very simple algorithm.
Mm-hmm.
Yeah. And Debbie has constructed that algorithm, and it's just basically what they use at Tampa General to identify, and I presume other places. So we don't have to calculate in the field a cardiac output.
right.
Okay.
All right,
It's
thank you.
blood pressure, oxygen saturation, mental acuity, and most important, ST elevation, myocardial infarction, ST elevation on ECG.
So, let me just, for the record here, clarify from my, from me being a former paramedic, if I have a patient my size, 240 pounds, y'all didn't hear that, 240 pound male, and the EKG shows a ST elevation MI, and my blood pressure is 90, I'm heading to one of those 3 hospitals. I'm heading to Tampa General, to St. Joe's, Maine, or to Admin Tampa, because I've got a ST elevation MI on the EKG, and I've got a blood pressure that probably is not normal for someone my size and age. Is that in a nutshell, is that it?
That was what I would say is the protocol.
Okay. So, so from a system perspective now, I'll change a little hats again. From a system, was there more, Dr. Hoffman?
Go ahead.
I was just gonna say, we may end up putting patients in cardiogenic shock-ready hospitals that don't need it, but I think that would be an error that we would prefer to err on the side of.
Yes. Okay.
Yeah, absolutely. Basically, this protocol is an extension of the criteria that have been developed for trauma, and we've implemented. So we don't have to go, we don't have to reinvent a lot of wheels.
So from a system perspective, the state has a trauma system. The state has a stroke system. Currently, the state of Florida does not have such a system, but it's being worked on.
Yes.
All right. So in the meantime, while it's being worked on, what that does system-wise is it puts it back to the individual EMS agencies and onto their physician medical directors to agree to this protocol. Because the physician.
That is one of the goals.
The physician.
Of our meeting.
Yeah, the physician medical director at each EMS agency will have to sign off that, yes, I want my EMS agency, if they have a patient that meets these criterias, then they are to transport the patient to one of these three hospitals.
If they are within 30 minutes.
Within 30 minutes, part of the protocol.
I mean, you know, we had the last EMPC meeting where Sun City Center, the representative from Sun City Center got caught in that major accident that closed I-95. And then we have Aeromed or Bayflight or one of the others that could, in an emergency situation like that, can transport the patient. So we have alternative approaches of transportation.
So, so just so everyone understands, the EMPC, the EMPC does not have authority to set protocol. The EMPC can have these discussions, and we come to agreements on what protocol should be and what the system should be. But the actual protocol, because we do not have a countywide physician medical director over all of EMS. We don't have that in this county. Other counties in the state have that. One physician oversees all EMS in the county. We do not have that here in Hillsborough County. We are back to the EMPC develops a system, puts this together, and in the end, right now, because there is no, again, no countywide physician to sign off on this, and there is no state system to sign off on this to say, yes, you can do this, we're back to the physician medical directors at each EMS agency agreeing with what we develop here and through the EMPC and signing off individually. So just so you understand where things are with the EMPC. The EMPC can't just say, this is what's going to happen. The EMPC will develop this with your help. And then we will have to get the physician medical directors from the EMS agencies on board. A question, is there any concerns for Air Medical? Air Medical doesn't have any trouble flying patients in cardiogenic shock, do they? No. No, okay.
They do have, you know, they fly trauma patients, and you can think of it as cardiogenic shock patients are no different than trauma patients.
Okay, I figured as much, but you know, being a little bit specialized, I just wanted to throw it out there and make sure.
Okay, well, they're going to be part of the specific protocol. What I'd like to do is next just put together a committee, and I want to make sure there's at least representatives of all the EMS, all the level 1s and level 2s and level 3s, because they have to agree to the protocol. And this committee, I'd like to start meeting on a fairly regular basis I know it's difficult, but I'd like to, with a goal that we will have a protocol ready by our next cardiogenic, STEMI committee meeting in August. So we will have 3 months to work on this with a protocol, and I will ask Debbie to help us with the taking the Tampa General Protocol. I would like you to help with the Advent Protocol, and we can get the St. Joe's, Maine to, we need a representative from St. Joe's, Maine, who will help us with this. And then we can go from there, and we can, what are the requirements, the things that have to be, and then I want to get all the EMS services to develop a shock recognition protocol for the EMS people. So they will know that if they have a patient who is an impending shock, they know they can identify them. Basically, it's not much different than what was done for the identification of STEMI. That Dave Travis did a great job with. Because of him, there's a great deal of security that computer interpreted ECGs are reliable and can identify a STEMI. Yes, you're going to have to go off and absolutely no. I told you. Thank you for coming, Dr. Hoffman. And thank you so much, and I'll be in touch with you after pass under. Yes, sir. Come here. We love you.
I'm rather new to Hillsborough County, but I just want to make sure from the entire group that, of course, recognizing STEMI through 12 lead. So we have the capability throughout the county to establish a 12 lead in the field, also
Yes.
to send it
Yes.
and have it validated and verified. And then when they arrive, they can do that again to confirm to either have quick access to the cath lab or to have whatever care.
The goal is that if they have a STEMI, and by the way, what Dave Travis helped really establish was the accuracy of computer interpreted ECGs.
Great.
And if they have an interpretation that says STEMI, they can go directly to the cath lab. The cath lab is alerted when you pick up the patient.
Great.
And they are taken directly to the cath lab. By the way, there were 2 papers in the literature about direct cath lab bypass. One was published in Circulation out of St. Paul, Minnesota in 2010, and the other was published in the Emergency Medicine Journal from the Royal Free Hospital in London. And I helped Robbie Rackett, who developed that, get that paper published.
Oh, that's great. Thank you. And I am familiar with those through some research that I had also done too. But I just wanted to confirm that. Thank you.
Absolutely. Any other questions? So I propose that those who would like to serve on the committee to develop a protocol for the hospitals should contact me, and we can set up a meeting. And then the EMS services I will ask that they send me the committee for developing the in the field protocol. I can send out, I think, Mike, we sent out Debbie's ideas for that, but develop the EMS cardiogenic shock protocol. So I think, and then we can merge those committees. I would like to also think about who would like to help develop this, the Cqi process, because without a countywide Cqi process, we just won't have enough robust information to know how the system is working, what things need to be changed, and how to move it forward. Okay, so
So Dr. Dr. Strom, you want one work group
yes.
to look at what for inside the hospital?
In
What
a
protocol?
hospital-based, cardiogenic shock protocol, another work group to.
No, okay, so stay on the one work group for the hospitals for me just a second, so I understand. And that protocol would be for the level 2 and 3 centers?
Would be for the level 1 with also, but it would include the level 2 and 3 to make sure there is seamless coordination. What you don't want is a patient to wind up because patients are going to arrive to level 2 and level 3.
Mm-hmm.
And what we don't want is people sitting there scratching their heads.
Okay, so are you talking transfer protocols, or are you talking protocols for treatment in the hospital?
Protocol for treatment in the hospital.
Because treatment in the hospital, that is up to the physicians in the hospital, and that's not really the purview of the EMPC to dictate treatment protocols for in-hospital. Transfer guidelines is purview of the EMPC, but so are you talking transfer guidelines between the hospitals?
I think I understand what you're saying. I think one of the things that you have to look at when you're looking at this process is being sure that there's a seamless process in the field so that EMS can recognize a cardiogenic shock patient and not necessarily take them to a freestanding ED that's nearby to then have them sent out to another hospital. So the out of hospital and the hospital process work together for that EMS protocol, because we need to be sure that they're identifying them correctly in the field and not taking them to a freestanding ED first, because it's the closest, and then have to transfer them out somewhere else. So the out of hospital is just as important as the in hospital, if I'm making sense.
Yeah, absolutely. Any other comments?
From ER to ER, so you get that patient the last 30 seconds before he bolts in the door, drops his pressure, you're a level 3 spot with that. Can you transfer from ER to another ER on this protocol?
It should be good. If the patient drops the blood pressure, they should be transferred to a level 1 hospital. Yeah, but that's okay. That's exactly the protocol. There are guidelines that they should be transferred with it, and the DI out should be less than 30 minutes, and they should go to a cardiogenic shock hospital.
And those are preset protocols. You're right. Those need to be set up just like trauma. Someone is a drop off with a gunshot wound or stab wound, they immediately call ALS and transport them right out. So you're right.
And it should be to the nearest hospital. One of the problems we have in Hillsborough County without a countywide medical director is we have hospitals that systems that transfer intra-system as opposed to the best place. I heard about one system that was transferring patients across the bay, their cardiogenic shocks. That's not a good thing. It should be to the closest hospital. Yeah, okay.
So for those online, the question was, if a MI patient comes through the ER door and as soon as they come through the ER door, their pressure drops. So now you don't just have a STEMI patient. Now you have a STEMI patient that is suddenly showing the signs of cardiogenic shock. Can a transfer be done ER to ER? And the simple answer is yes, it can. I mean, you can't just go up to drop the pressure, spin around and back the ambulance and get down the road to the next hospital. That's a COBRA violation. But yeah, that's the whole That's the whole point of this, is that whoever finds the patient with a STEMI and low blood pressure, they need to be transferred to
Well,
a shock
not
center.
just low blood pressure, but other signs.
Other signs and symptoms,
The-
yes,
the-
but yeah.
yeah.
So that sounds all well and good, and I don't disagree with that in theory, but the reality of what we're facing in our other emergency departments is that transfers out are incredibly difficult, even for trauma patients with our robust system. Getting an accepting facility and then getting a transport truck to get the patient is a huge lift right now. So I just want to caution that we.
Well, this will be part of our,
Right.
what our goal is. And we'll have to work out the mechanisms. And yes, it isn't easy, especially now. We just went through 3 years of hell, but we have to think in terms of the future, that we can develop a systems approach to getting it done.
Don't disagree, but the 30-minute is not the
Well,
reality.
that's the current AHA guidelines. So we'll have to figure out how we accomplish this in this county.
So back to the work groups. Do you want to do 2 separate work groups, one for the hospitals and one for the pre-hospital?
Yes.
Or should they be all one work group together?
Okay, fine. I'll be happy to go with.
That's my opinion.
Okay.
I
Okay,
think
fine.
logistically it would be
Okay,
easier.
that'd be easier and we can get that people together.
Um,
Because we should have a working relationship between EMS and the facilities. So doing it together, I think, would behoove us as a team.
I agree. I definitely agree with you. And by the way, anything I'm saying here is not in stone. It's for discussion purposes. I want to hear pushback. Thank you.
So the work groups should be
Representatives from,
should be the medical directors and the rescue chiefs from the EMS agencies, and then who from the hospitals?
obviously.
Because we're getting back into the folks that are sitting here in front of us being the work group, so is it work groups are supposed to be small focused
Yes,
things,
they
but if
can be at least one representative who deals with acute STEMI patients.
About ED medical directors and cardiologists.
That would be ideal. Anybody have any other?
So we're back essentially to the list for this committee. as a
No,
whole.
not the whole list. No, actually, we'll keep it down. I want to keep it to one, at least potential that people, that focused enough. So if we can get at least one person from each hospital, I would like to see the ED director and the cath lab director from the level 1 hospitals, and at least one representative from the level 2 and level 3.
This is Melissa Cranius. I'm the cardiovascular service line manager for Baycare, and I can represent St. Joseph's Hospital.
Ma'am, we're having trouble hearing you in the room. Can you step closer to the microphone, or is it our volume here in the room?
It might be the volume. Can you hear me better?
Yeah, that's better. Thank you.
Okay. I was just saying my name is Melissa Cranius. I'm the cardiovascular service line manager for Baycare, and I can represent St. Joseph's Hospital on that committee.
Okay, thank you. I think Dr. Strom and Dr. Sand and I need to put our heads together as to who to bring with this work group.
Just tell them to email their name.
So, yeah, you certainly, if anyone has any suggestions as to who should be on this work group, you can email it. You can email it to me. And anyone we're missing, we'll reach out from there.
I do have a question, though, about what you were speaking to earlier about the shock patients. So STEMI shock, when they are showing up at level 2 facilities, generally they're going directly to the cath lab to be stabilized, possibly have mechanical support, and then hub and spoke model, stabilized and then transferred out. So are you speaking to something different than that with those patients? Obviously, you're saying if EMS recognizes that prior to them arriving at the hospital, that they would go to a level 1 facility. But for walk-ins and for patients that have already arrived, that's the expectation, or is it different than that?
That is a medical decision at the hospital, but if the hospital has the capability to stabilize them before transfer, that would be medically appropriate. You don't want to put a patient in an EMS who's got a blood pressure of 60, a pH of 6.7, and who's has an oxygen saturation of 50% in an ambulance, when you can basically stabilize them quickly before transfer.
Great. That's what I was hoping you would say. Thank you.
And it's my understanding that once you stabilize them, you're actually not doing a transfer from the ED to the ED.
Right.
You're doing a transfer from your ED as an inpatient elsewhere. So you're setting up transfer through the transfer facility. Like for Advent Health, it's our transfer center. And they set up transfer that way.
Yes, but we're going to have a protocol so the transfer center knows that this is a cardiogenic shock patient who is being transferred for a more advanced care for cardiogenic shock, and we don't have 3 days to sit around here.
It seems like you're going to have to accommodate that person that's in the ER, go to the cath lab, they've already activated the cardiac work system, and on their way there, they're getting cardiogenic shock. You've got an impeller right there that you can put in, and then move them somewhere.
Yeah, absolutely. Absolutely. It's basically how do you stabilize the patient so that they can be transferred for a more advanced care?
I think our issue is going to become there are STEMI docs, not shock folks that would not be on the shock team necessarily. That's been
Sir, can we get you to step to a microphone? So.
My name's Jim Smith. I'm out of Advent Health. So one of the issues is that some of your STEMI docs who now are attached to that patient are not shock doctors. So they're either slow to put in mechanical support or aren't comfortable with that. We need to be sure that those folks are.
That's why the hospitals need to establish a
shock team. Right.
Yes.
Which has been shown to have improved survival just by virtue of having the team.
Absolutely.
So then the problem becomes, do you let people take STEMI call that are not comfortable with shock call? And that may become a numbers process.
I think there will be people who do that because there will be STEMIs who are not in shock going to level 2 centers for primary PCI.
Right.
So I think that once the shock is identified, the shock team has to be brought in.
I think that makes sense in the hospital then.
Right.
But if you're going to call these 3 centers that you're going to take these folks to, if it's a STEMI that turns into something else, they got to have a shock team.
Yes.
Maybe a secondary team that does that.
Yes.
Okay, good. Thank you.
If I could step back just for a second. In theory, if you receive the patient at your facility and you're transferring them out for a higher level of care, in theory, you would be transferring them to the next facility and as a direct admit into whatever specialty care they need up on the floor. The reality is that may not happen. It may be an ER to ER transfer simply because there's no bed availability, they're full of COVID, they're this or this. My understanding is that there's a lot more ER to ER transfers, even though there's a accepting physician at the receiving facility. that accepting physician says, just transfer them to the ER. I'll see them in the ER at my hospital. So, so it may in effect be an ER to ER transfer, even though on paper it is an ER to admission ER, or to a floor transfer. They're not going to the receiving ER to see the ER doc and staff, even though it is the ER staff that is going to take care of that patient. You are technically transferring them to a receiving physician at the receiving hospital. It just happens to be that they are receiving them in a bed in the ER.
So you're saying it's an ER to the ER in the sense of the location, but they would be admitted to the level of care could be held in the
Held in the ER, yes.
What might be nice is to do, because it is very common ER to ER, if this is something that we have we go to that higher level of care, we have that multidisciplinary team that maybe meets them shortly after arrival. That would be common, like something we do with our aortic dissections or that kind of thing, ER to ER often. We get that multidisciplinary team down there very quickly.
Yeah. Dr. Shepherd, why does the ER physician also see them? Just because the ER physician, it's their ER at that time? And okay, so it is a visit. So it is considered an ER visit. So the ER staff has to do that. Okay. Dr. Cqi, you back?
Come up to the mic here, please.
Yeah.
If we're talking about a patient that just is in shock,
Come on up. You're an ER doc, for God's sakes, get up here. When did you become bashful?
Just loud. I was saying, just agreeing with your points, if when you do ER to ER transfer, it's usually because the patient's relatively unstable. And so you're going to want somebody to see them to make sure that nothing has changed en route. Not saying anything against EMS or anything like that, but stuff happens sometimes and there's more equipment in the emergency department. So if anything the patient does decompensate, you're going to want somebody to at least get them stable enough to go to the shock team or the STEMI team or cath lab or whatever their next intervention is. So it's very common, just like with trauma transfers, they go ER to ER to make sure they're stable before they get admitted. Same thing with this. It's
But
kind
they
of
should be, the shock team, the shock team should be alerted at because what you don't want is somebody coming to your ER and then you got getting everybody together. The point is the pre-alert is very important so that you have everybody waiting and ready.
Yeah, and that's, I think, where the multidisciplinary team comes in.
Yeah,
If
absolutely.
They're known, then they're waiting for them in the ED, just like a stroke or a trauma
Right,
or a
absolutely.
STEMI. Everyone's ready
Exactly
for them. But
like a stroke or trauma. Any other comments?
I think we also need to be conscious about the types of patients we're putting in these ALS vehicles.
Mhm.
I think a lot of our organizations.
Sorry.
But a lot of our organizations may need additional training. I think if we don't do that, what's going to end up happening is they're going to take a resource from our hospital, whether it be a balloon pump patient, and now it's needing an RN rider to come with that patient. And so we just need to make sure that we're equipping our advanced ALS critical care providers with the resources and the training they need to move these patients.
That'll be part of developing the out of hospital protocol.
Right. And so that'll take a lot of support from our hospital systems, but we do need to look into what it will take to support them so that we have enough resources to move these patients if necessary.
Yep. Totally agree. Okay. What I'd like to do is let's get the working group together And these questions should should we have another meeting of just the working STEMI group, cardiogenic shock group, before the next EMPC meeting on May 16th?
Yeah, the next EMPC, the full EMPC meeting is Monday, May 16th in the afternoon. That morning, I've reserved time here for the committees to meet.
Okay.
So I was going to suggest that would be a good time if we can get all those stakeholders together, that sometime that morning before the EMPC to have that work group meet that morning.
Well, that would be a good idea. I agree.
And then while we're on that topic, the next cardiac STEMI committee meeting, this full committee, we will schedule sometime after that.
Okay. Is that okay with everybody? Okay. The performance improvement program, TGH has a program to extract NCR data. Obviously, the other hospitals submit their data to the NCDR, and we just have to set up a way to a central repository. And that's going to be part of I think the work group can deal with that. We don't have to have too complex data, but we do have to have data that will tell us how the system is performing. One of the things I did way back when dinosaurs ruled the earth is I was working for Grumman one summer between engineering school and medical school as a reliability engineer on the LEM project. And my title was systems engineer. And I think with systems engineering approach, we might get one of the universities involved to help us with this.
Melissa from Baycare, did you still have your hand up? Did you have another question, comment?
No, I'm sorry. Thank you.
No worries, just checking.
Okay, we don't want to make sure everybody's questions are answered. Okay, EMS PCI Center update on effective ECG transmission on performance. Anybody have any data on that?
So at this point, we'll continue on with the rest of the agenda.
Well, yes, I think we'll put that off to the next EMPC meeting, the STEMI meeting. ED bypass outcome data. Well, Charlie, anything? Okay. Sudden cardiac arrest. Is Ashley Capucci here? No, because Hillsborough County is continuing their program with CPR and AED education in the Hillsborough Public Schools. In fact, they're advancing, their program is becoming more robust. So we'll table that until she's able to attend a meeting. Update on sudden cardiac arrest. Any comments? Charlie? Anybody have any comments? Any updates? Okay. AED use in the community. I see there's an AED in that sheriff's car out there. Okay. Hypothermia. Obviously, all the hospitals that are taking care of out-of-hospital cardiac arrest must have capability to provide temperature-targeted hypothermia, which is still undergoing a lot of changes as new data emerges. Anybody have any updates? Any new business? Well, I motion to adjourn? Second, third, fourth? Well, we'll aim for the working group meeting on May 6th in the morning.
16th.
May 16th. And thank you very much for coming today. And have a happy holidays. Even if you're going to be eating a lot of matzah or Easter eggs. By the way, I can't find chicken fat because of bird flu. Ah.